You're watching How to Teach a Procedural Skill, produced by GP Supervision Australia and presented by Dr. Coralie Endean and Dr. Ben Abbot. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
It's a great pleasure to kick off a topic that I think is something I always think as an educator that we have de-skilled, broadly speaking, in over recent times in general practice. I think most of us do very basic procedural skills, but some of the more complex skills really have been lost and we've sort of handed over. So I'm thrilled that we're running a session on how to teach a procedural skill, how we as supervisors can equip our registrars and RG registrars to undertake office-type procedures. Coralie and Ben, would you like to introduce yourselves?
Hi, I'm Coralie. I'm one of the lead medical educators for Supervisor Support at ACRRRM, but I'm also a rural generalist with ASTs in surgery, ED and O&G. So I really feel like I've got skin in the game when it comes to procedural skills, as does Ben, who's the head honcho person in ACRRRM for all things proceduralist in surgery. Over to you, Ben.
So I'm Ben, and I've been a surgical and obstetric rural generalist, mostly based in South Australia, for coming up 30 years, previously called a GP surgeon, but not allowed to do that anymore. And I have a real interest in trying to pass on the skills and knowledge that I've learnt over my journey. And so hopefully we'll be able to share some of that stuff. And just pointing out that that's me in the black hat.
Great to have you along. And so what is this about? Essentially teaching a procedural skill to your trainees, so that how to kind of break it up into a multi-part skill. Of course, importantly, I think that dot point's been merged with the top one, provide patient-centred informed care into procedural skill teaching, and obviously incorporating patient safety. So I'll hand over to you, Ben and Coralie.
Okay, if any of you have ever attended any ACRRRM or RMA dinners, particularly the award dinners, just about everybody who gets up and receives an award starts more or less by saying that they stand on the shoulders of giants. And one of the things that I think we have the opportunity of doing as supervisors to some extent, not necessarily being giants, but being able to give a hand up or a leg up for our registrars. And I'm really conscious of this particular book, which I've read a few times, and the 10,000 hour rule that some of you may be aware of. Malcolm Gladwell, who wrote this Outliers book, which I recommend that all of you have a read of at some stage, in one of his chapters discusses the 10,000 hour rule based on the Berlin Academy of Music, basically into which they interviewed some violinists who were hoping to study at the academy, and they divided them into people who were stars, basically virtuosos, people who were good, and people who would only ever become music teachers. As it turned out, on their application interviews, those hours that the applicants had already achieved related, so the stars were 10,000 hours of practice already. The good ones had 8,000 hours under their belt, and the ones that would only ever become music teachers had only done 4,000 hours. Now, what they did is they then followed them all over their ensuing years, and basically when all of them got to 10,000 hours, they were all stars, virtuosos. Why do I mention this? Well, ACRRRM training is only 8,000 hours, basically, because 10,000 hours is 40 hours a week, full-time for 5 years. And when you break down ACRRRM training or RACGP training, there's probably only 2 years, so 4,000 hours, that people get to experience within a general practice type setting. So at the end of that time, people have achieved their fellowship. So maybe they're still at the music teacher stage and not at the virtuoso stage. And what we really need to try and concentrate on is how we can speed up that process so that people are moving through that perhaps faster than the 10,000 hour rule. And I guess that's part of the purpose of discussion. So I'm going to hand over to Coralie.
So all of you will know this rubric really well. So basically we all start off with skill acquisition where we're unconsciously incompetent. We have an aha moment at some stage, normally while looking at someone who's really good and go, oh, well, maybe I'm not so good at that thing. Then we move on with a great deal of effort into conscious competence and finally, hopefully, into unconscious competence, where most of us will be at now. Over to you, Ben.
I recently had a discussion with one of my registrars, a female, who said that she would not do a PR examination just as a procedural skill. She was only thinking about the role for them within doing prostate examinations. She was concerned about meeting the recipients of these examinations within the community. And we ended up having a long discussion about PR exams. And although it's not one of the technical skills that we get to teach very often, and getting back to some of the stuff that Coralie was talking about, unconsciously incompetent, there's a lot of things that sit behind procedural skills or even physical examination that's not just about the actual skill. And just in thinking about this, and when I was thinking about it with my registrar, I described my first PR examination, and I have here a photo of one of my medical students, and I can't show his face because he's a professional. Anyway, he's in the standard position that you would expect a patient to be receiving a PR examination. I was seated in a room with a consultant, 3 other medical students, and about to embark on this before the consultant reviewed my findings. And the problem is I'm left-handed, and I do everything left-handed, including my first PR examination, which is sort of going in the wrong way. And this was unknowingly entering into, there was no way I could ever actually achieve that. And so my findings were basically zero. I think that some of the stuff we have to do when we're preparing for these type of procedures or examinations is work out what some of the stumbling blocks are going to be first. And for me, it was my left-handedness, but nobody considered that at the time. And certainly the room wasn't prepared for that. I was going to talk about my first sigmoidoscopy, which was more horrific, but I won't share that story. Needless to say that there are a number of factors that are not just logistical, but can also be emotional that need to be considered when teaching somebody a skill. And so it's often worthwhile going through some of these things in a non-live model first, which is what this photo is about. I'm just going to pass on to Coralie, who's going to then talk more on the stages.
So this is just what we were talking about before. So basically, this is where we fit into the picture. So your registrar has looked over to see what you're doing in the treatment room, and you're cutting out a cancer, and they've gone, oh, I probably should have infiltrated all the way out to where I was going to put those sutures in and not just where I was cutting. And so they've had that aha moment, and they've gone from step 1 to step 2 to conscious incompetence. And now this is the bit that you can actually help in. And this is the step from conscious incompetence to conscious competence. It's painful and it requires a bit of tact, but you get all of that positive reinforcement and feedback from the registrar at the other end. This is just a plug for using yarning circles for this particular skill set as well. So using the use of graphics and talking around subjects can be really useful for all people, not just First Nations people, and it positivates, if that's a word, First Nations culture while we're teaching. Everyone knows the Fitz and Potsner stages of motor skill learning. There's a cognitive stage, which when you're thinking about something, it's really hard to actually think about it and use your hands at the same time. And so everything's sort of very jerky and stepwise, and it creates a lot of cognitive load to think through those steps. There's the associative stage where you start getting bits of it start coming. but there's still, you've got to think about what the next bit's going to be. And then there's the autonomous stage where you don't really require any thinking process whatsoever, and it's all pretty automatic. You can look at various different models for teaching. George and Dado was probably the first one who said the 5-stage approach is conceptualization, visualization, verbalization by the supervisor, then verbalization by the learner as they're doing the same task, and then repetition. So practice. So we started our journey with that. Then we modified that with breaking that down into structural steps. And you can use simulation, or you can use little diagrams for each structural step, or just a break of cognition and then move on to the next step. And so when I went through the surgical training program, the boss would do things like, he'd say, all right, you can close this wound, right? And then the next time we did that operation, he might say, you can open this wound. At some stage, you end up with about 10 or 15 little steps that when you add them together, you can finally do the operation. It comes as a great surprise to most surgical trainees that they're actually able to do that, but that's how they're able to do that. The next point I should make is the provision of immediate feedback. This is really critically important. You can't give too much cognitive load to people because otherwise they just won't take it all in. But it is really important to give them immediate feedback if they're doing something terribly wrong, okay, that will harm the patient or that is a step. You don't want them to implant into their muscle memory a wrong thing. So that provision of that immediate feedback, the way I view this is, so you're teaching your dog, say, not to jump up on you, then you need to tell the dog right then, don't do that. Otherwise, it's no point saying it 5 minutes down the track and the dog will not connect the two things together. So you develop your competency slowly, and you need to determine your competency to a level, to an achievable level by an assessment. And then after that, you need to plan for deliberate practice to cement that into muscle memory long term. So this is what I was talking about, cognitive load theory. We all only have a limited amount of space in our head. Probably heard about the list of 7 things, or other people have a list of 3 things. I suspect I do. But it really hinders learning and translation from short-term memory into long-term memory. And the more you can remove that cognitive load, the better things can be and the easier it is to learn. And that's making it a stepwise fashion. That's why we do those steps. Providing that clear, timely instruction, that immediate positive and negative reinforcement, but try to cut that down into a small amount as possible because you don't want to correct every little single step, otherwise it just won't be taken in. Putting the steps back together and providing assessment. Now, this is you guys, okay? You guys are unconsciously competent. You are an all-singing, all-dancing band, and you can perform a procedure and make it look just so easy. And it is so difficult when you're a registrar and you haven't actually done that procedure before. You feel like every little finger movement is outrageously, almost like you've got Tourette's. But the thing is, you may be an expert at that procedure, but you may not be a good teacher because all of this has gone completely into muscle memory and you've forgotten all of the small steps it took to get to that point. So you've got to deconstruct all of that. And you can do that with task analysis. So what you do is you visualize the procedure, you write down the key steps in it, you identify 3 things, the motor skills, the cognitive, and then the decision-making skills in each step. Okay, which when I say the decision-making skills there, I'm really talking about the key pitfalls. And then you reconstruct the task to see if anything's missing. And that forms the basis of your competency checklist and then your assessment tool at the end as well. So task analysis is good for 2 reasons, okay? It helps them learn, but it also allows you to have a minimum competency standard at the end of it. And the task analysis is how we do our DOPS forms and other forms like that. So just want to share with you, as I said, I was an ex-surgical registrar. I remember having this conversation about why we should and why we shouldn't be doing this thing. And then both of us looked down and we saw this absolutely terrified patient. How do we go about doing consent? How do we go about talking to the patient before and after the procedure? So I just want to put a plug in here for the forgotten skill set, which is us, isn't it? This is actually something we don't teach very well, and that is the preparation before a procedure, which is a consent, doing patient-centered care. So telling the patient, I laughingly tell patients that we're going to have a safe word, which will be stop, but whatever it is that puts the patient at their ease, make sure there's a patient advocate in the room, whether that's you or your nurse or someone. Then there's a skill, which is a thing that registrars really want to focus on because they want to get good at that thing. But then there's the aftercare as well. So talking through the care, which may be modified. You may do patient-centered care. So I remember having this guy out at Moree who'd promised me faithfully that after I did a full-thickness skin graft on his hand, that he would look after that. And then he said, but I'm going back to fencing this afternoon. So I put him in a half cast. I mean, it was the only way I could make it safe for him to continue to do what he was doing, because I knew he was going to do it anyway, although that wasn't the best treatment for what you came to me with anyway. And yeah, make sure you enter things into a recall system. If we had time, I'd say add the preparation and aftercare skills into your checklist. And you certainly should when you're doing your own checklist, because I want you all to do this task analysis when we're finished. Go home and do this as practice with your registrars. Do something, choose a skill. And you're right, Simon, it need not be a procedural skill, but it lends itself best to procedural skills. And add in preparation and aftercare steps into your checklist. This is actually Peyton's method: demonstration, deconstruction, comprehension, performance, and error correction. You've all done it. The other thing I would say is at the very end of all of this, you've got to do deliberate practice. And so deliberate practice is where you then go and say, well, okay, I've got the registrar up to a standard. He's now doing a simple elliptical incision. So what I'm going to do is I'm going to put together some lists. So once a week, we're going to do 4 of these. Yep. And I'm going to stick my head in and see how he's going and give him expert feedback, immediate feedback, expert guidance, I should say. And that way you can get better over time quicker. So I really like you all to put this, go home and put all this into practice. This is what it looks like. The form on the right-hand side is what I developed using task analysis for a simple elliptical incision. It's a 1-pager. Any of you guys can do this. If you're feeling frustrated at a registrar not quite getting what's going on, then give it a really good red hot shot. The other thing to note is that task analysis is what we use for all of our forms for assessment. So on the left-hand side there's the DOPS form, which I'm sure you're all familiar with. Even your supervisor reports are, in a way, task analysis. So I would encourage you to have a go. And that's it. Any questions?
I would just like to pick up on that final point you made, Coralie, around the importance of deliberate practice. The whole notion of developing procedural skills in registrars is one thing, but if it all just tails off after that, yeah, they lose confidence. I remember learning to do toenails and was really confident, and then I just didn't do them for a long, long time, and I've just lost that level of confidence. So somehow sort of maintaining the connection.
A procedural skill is not necessarily taking out an appendix or doing toenails. It is something potentially less invasive, but is still something that needs to be broken down into smaller chunks for people to do the whole correctly.
It's like the old adage, how do you eat an elephant? Well, one bite at a time.
Yeah, thanks, Ben. That's an excellent point. And I think sadly, unfortunately, our students are probably exiting medical school less adept in skills than we were, and us much less adept than our peers before us. And I think, there's quite a lot of active de-skilling occurs in many training settings. Sue?
I'm quite a big fan of actually using YouTube as a skill reminder for things that I've done in the past but haven't done for a bit, just because you can break it down into little bits. You can stop and just go back over it if you need to. Obviously, it needs to be a reliable source, but yeah, every now and then I'm in a situation where I need to do something that I haven't done for a bit. I find it a useful reassurance, I think.
So what I might do is follow that up with you at the end of this to maybe collate some reliable sources to get some good YouTube clips, because you're right, there's some bad ones and there's useful ones, but maybe we can collate a little list of good resources out there. I would really like to say thank you, a very, very big thank you to the ACRRM mob, particularly Ben and Coralie, who suggested and developed and delivered. I've found it really, really useful, a good reminder, I think, of doing this in a structured way and the importance of doing that. Lovely to have you along. Been good, and thanks very much. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.